Up next, Spencer King is joined by Dr. John Camm, Professor of Clinical Cardiology at St. George's University in London, to discuss assessing stroke risk, CHADS-2 versus CHADS-2 DS2 VASC.
John, welcome to ACCEL.
Thank you very much, Spencer.
There's some impetus for all this interest in how we risk stratify patients with atrial fibrillation. What's the impetus for this change?
Well, I think two things. Firstly, we decided in Europe to rewrite the guidelines for atrial fibrillation in 2010. And secondly, at that time, we were envisaging the new oral anticoagulants becoming available. And as you know, with the new oral anticoagulants, they're at least as effective as warfarin. Some seem even better at reducing stroke and systemic embolism, but they're associated with less intracranial hemorrhage. And for that reason, we thought it was time to reassess stroke risk stratification in atrial fibrillation patients.
So basically, the question always is, you've got atrial fibrillation, do you put the person on anticoagulation or not? And the new agents may alter the thinking about that, I guess.
Yes, because they do have less intracranial hemorrhage associated with them, and that, of course, is the very big concern about using oral anticoagulants, and for that reason, we thought it was time to reappraise the whole thing.
So I think most of our listeners are familiar to some degree with the CHAD score that they've had for a long time, but help us understand the changes.
Well, we have been using in both Europe and America the CHADS-2 scheme, and as everyone knows, that's congestive heart failure, a history of hypertension, age equal to or over 75, diabetes, or a history of stroke or TIA. The latter having 2 points and the other factors having 1 point. You add them all up, and that gives you the annual risk of stroke. Now, when this scheme was devised, we had obviously a lot of patients who fell in the 0 and 1 levels of the CHADS-2 scheme. And these were the patients where it was not quite clear whether we should use an anticoagulant or not, because the risk varied within these groups up to, with a CHADS-2 score of 1, up to about 3 or 4% per annum. So that wasn't the average risk, but some patients had
So we're sort of accepting stroke risk of that amount, 3 to 4%, before getting on this anticoagulation.
Before saying that anticoagulants are definitely necessary.
Yeah.
And there were, however, a number of other risk factors that were well known for many years and have always featured in the guidelines but were not incorporated in the acronym. And these included vascular disease, that's peripheral vascular disease, coronary disease, or aortic disease, age 65 to 74, and female gender. And what CHADS-VASC is all about is incorporating these 3 new risk factors, each with 1 point, into the scoring system. And the other change that occurs in the CHADS-VASC scheme is that we give 2 points for age equal to or over 75. So the scoring system is a little different, and basically the risk is equal to either the sum of the scores or double the sum of the scores. It's somewhere between those two. So for a score of 0, the risk is less than 1%. For a score of 1, it's between 1 and 2%. So a score of 2, between 2 and 4%.
Yeah, I don't expect everybody to memorize this from our conversation, but they can look it up very easily. But the effect of this, what is the effect of the new CHADS-VASC score? What does it do?
Well, the effect is that we're able to subdivide the patients at the lower end of the risk into those that have a truly low risk and those that have quite a substantial risk. For example, we can find within patients that have a CHADS-2 score of 1, we can find patients who have risks that range from 2% to 8% per year. So, for example, CHADS-2 score of 1. If they're also female, if they're also aged 65, if they also have vascular disease, etc., if they have other CHADS-VASc factors, then their annual risk can go up to 8% per annum.
So as we're counseling a patient and they say, well, I'm in a CHADS risk of 1, the old CHADS 2, for instance, and that means I'm not going to have a stroke, that's not necessarily true.
That is not necessarily true. And I think that we now need to think a little more carefully, because we have very effective treatments, and these treatments are less complicated than the previous treatment with vitamin K antagonists.
So it moves more people into the appropriateness, I would say, for anticoagulation than before. And of course, what people worry about who have atrial fib, who don't want to go on warfarin anticoagulation, in addition to their concern that it's rat poison, is that they're going to bleed. So you think the game has changed with the new agents?
Yes, the game definitely has changed, and we're beginning to bring our guidelines up to date with that change. And as these new oral anticoagulants become more and more used and we gain confidence with them, I'm sure we will want to look much more critically at the lower end of the risk spectrum to decide if some of those patients need anticoagulation.
As a disclaimer, I guess this is not an endorsement per se of the new anticoagulant agents. It's more trying to balance the risk and benefit and decide who needs anticoagulation. Are there still people in the old CHADS 1 who now are, you think, at higher risk in the CHADS-VASc, who are still fine for a warfarin anticoagulation? Or
Oh, yes. We're not actually trying to do away with the use of vitamin K antagonists. We're just saying that now that we have better treatments, potentially better treatments at least, that we can think much more carefully about people who appear using the CHADS-2 scheme to be relatively low-risk patients for stroke. We can look at these more critically, and we can find amongst them patients who are at relatively high risk in whom we should be using anticoagulation as a primary strategy.
Well, I think this is going to be very helpful to all physicians caring for patients with atrial fibrillation. Will help us give more precise recommendations to our patients and maybe a reassurance to our patients that their risk-benefit is improved by anticoagulation. So I think it's a great contribution. Thank you so much for visiting with us on ACCEL.
Thank you very much, Spencer.